All right, everyone, welcome. So today, we're going to tackle a classic clinical scenario, gallstones. Now, for any medical trainee, this is absolute bread and butter stuff. But really understanding how a simple stone can spiral into a life-threatening emergency, well, that's a skill you have to master. We're going to walk through all those critical decision points together.
So here's our game plan. We're going to follow the patient's journey, starting with their initial pain, then see what happens when those stones get stuck, and learn how to recognize a true biliary emergency. After that, we'll dive into the right diagnostic workup and wrap up with the interventions and definitive care. So let's get started. Okay, so let's start where it all begins, with a patient in pain. This is a chief complaint you are going to see over and over again, in the clinic, in the ER, and on the wards. And there it is, the classic story, that severe right upper quadrant pain that hits right after a meal. Your pattern recognition should be going off like crazy, pointing you straight to the gallbladder. So the question is, what's actually causing this very specific type of pain? It all starts with cholelithiasis, which is just a fancy way of saying gallstones are present. The pain itself, which we call biliary colic, happens when one of those stones temporarily blocks the cystic duct. Think of it as the gallbladder's exit ramp. The gallbladder squeezes against that blockage, and that's what causes that intense, cramping pain. It usually gets better once the stone falls back. But what happens when it doesn't?
So, biliary colic on its own is, a temporary problem. But when that stone doesn't fall back, that's when we cross a line. We go from simple colic to a true obstruction, and believe me, things get a whole lot more serious. Where that wandering gallstone ends up is, well, it's everything. It literally determines the diagnosis, how sick the patient is, and our entire management plan. As trainees, learning to tell the difference between these two locations is an absolutely fundamental skill. And this slide lays it out perfectly. So think about it this way. If the stone gets permanently lodged in the cystic duct, you get acute cholecystitis. The gallbladder is blocked, pressure builds, and it gets inflamed and infected. That's what gives you that constant pain, the fever, a high white count, and that classic positive Murphy sign on your physical exam. But if that stone travels further down and gets stuck in the common bile duct, now it's choledocholithiasis. You're blocking the main drainage pipe for the entire liver. Bile backs up, and that leads to jaundice and that telltale rise in your cholestatic labs, like bilirubin and alk phos. Now, while cholecystitis is definitely serious, a stone in the common bile duct is a gateway to two huge, life-threatening problems: gallstone pancreatitis, and the one we're going to focus on right now, acute cholangitis. This is where a patient can get really sick really fast. Acute cholangitis is an infection in a blocked biliary tree, and let me be clear, it is a true medical emergency. You have to recognize these classic signs. Charcot's triad, that's fever, jaundice, and right upper quadrant pain, is your first big red flag. But if it progresses to Raynaud's pentad, where you add on hypotension and altered mental status, your patient is in septic shock. This is a 5-alarm fire, folks. Now, what's really cool about this slide is how it formalizes what we're already suspecting clinically. The Tokyo guidelines are an essential tool, and, they love to ask about these on exams. They help us go from just recognizing a pattern, like Charcot's triad, to making a really systematic diagnosis. Basically, you're looking for evidence of systemic inflammation, plus evidence of cholestasis or a blockage on imaging. For a suspected diagnosis, you need 1 from column A plus 1 from B or C. But to be definite, you need 1 from each column. It's a great structured way to approach a potential emergency. Okay, so we've got a potential emergency on our hands. The workup needs to be fast and focused, but there is a classic pitfall here that can really send you down the wrong rabbit hole if you're not paying attention. This is such a critical clinical pearl. Listen to this. Sometimes, as a gallstone passes through the common bile duct, it can cause this temporary but massive spike in the liver transaminases. We're talking about the AST and ALT, often shooting up into the thousands. And you know what that looks like? It looks exactly like acute viral hepatitis or some other major liver injury. So, what's the takeaway here? It's all about context. Before you order a massive, expensive workup for some rare liver disease, go back and listen to the patient's story. If they're describing that classic biliary pain, and then you see this bizarre lab pattern, you have got to think about a passing gallstone first. A good history is your most powerful and cheapest diagnostic tool here.
So once we've confirmed there's a stone in the common bile duct, especially if it's causing cholangitis, the clock is ticking. We have to get in there, decompress the system, and get that infected bile draining. And the go-to intervention for this is called an ERCP, or endoscopic retrograde cholangiopancreatography. This procedure is just incredible because it's both diagnostic and therapeutic all at once. The GI doc passes a scope down into the duodenum, finds that little opening, and threads a wire into the bile duct. From there, they can do a sphincterotomy to cut and widen the opening, dilate it with a balloon, and then literally go in with a basket or another balloon and sweep that stone right out. It resolves the obstruction and lets the bile drain. It's amazing.
So, this brings us to the final, and I mean absolutely crucial part of the management plan. We've put out the immediate fire, right? The stone is out of the common duct, the patient is feeling a whole lot better. But have we actually fixed the underlying problem? What about the factory that's making all these stones in the first place?
That ERCP? That was a rescue mission. It was a temporary fix. To stop this from ever happening again, to prevent another stone from wandering down that bile duct and causing another crisis, you have to get rid of the source. The gallbladder itself has got to go. And that right there brings us to the definitive cure, a cholecystectomy. The surgical removal of the gallbladder is what truly solves the problem for good. It's almost always done laparoscopically once the patient is stable and has recovered from the acute infection. So there you have it. From a simple pain after eating all the way to a major surgical procedure, that is the full clinical pathway. Understanding every single step from the colic to the obstruction to the emergency and finally to the cure, that's how you're going to safely navigate this incredibly common but potentially very dangerous clinical journey.